babies have problems with retinopathy of the prematurity? Okay. And then bronchopulmonary dysplasia, that's kind of sound like it. So, retinopathy of the prematurity. This happens because of the oxygen therapy that they have to have, and it causes vasoconstriction and hemorrhages occur, and it affects the retina, and it causes retinal detachment, and this often occurs leading to scar tissue, leading to visual impairment. So a lot of our preemies have visual impairment because of the high oxygen we have to use. They have tried to improve on this. Used to be a lot worse, and I think it's improved because they're not giving any more oxygen than that baby needs. That's the key. Because the oxygen, it affects that developing retinal vessels in the preterm babies. Our retinal vessels don't mature until like 42 to 43 weeks after conception, so they're not even mature at birth. I'm sorry? 42 to 43 weeks after conception. So even a couple weeks after they're born. So the key is not to give them any more oxygen than they need. And due to the decreased survival rate, that we're getting very low birth weight babies, we're saving a lot of little bitty babies that probably need more oxygen than our older preterm babies. It's going to be potentially worse, but they're trying to really safeguard and really monitor that oxygen level so they don't give it too much. Another problem that we can find with our preterm babies is bronchopulmonary dysplasia, and this is what Stephanie's baby had. And this is caused by the trauma of the pressure ventilation, scars the lungs, and also the high oxygen toxicity. These babies have tachypnea, retractions, nasal flaring, they have to work hard to breathe. So a lot of times they are on long-term oxygen. They have long-term oxygen dependence. How long was your baby on oxygen?
He was on for 3 or 4 months after.
Okay, well that's not too bad. That's not too bad.
We had it was a lot.
Yeah.
He had a heart monitor, and he worked on, like, he had to work constantly with the O2s, and then, like, you had to do these tests to get him off of it, to make sure he can maintain his oxygen level.
Full-time job, yeah. So, and these babies are at higher risk of having more infections because their lungs aren't as strong for the first few years of life, too. Did they have a lot of respiratory problems when they were young?
They were, like, almost guaranteed he would have asthma, and he does not.
Wow.
Yeah, he played baseball for 2 years.
Wow.
No issues at all.
Awesome. That's great. Good. So a lot of times these babies are treated with oxygen at home, good nutrition. Were they on medications like diuretics or?
Nothing like that. They were more on like breathing, like on the floor, stuff like
Okay,
that.
bronchodilators.
Yeah.
Yeah. Did they have a patent ductus arteriosus? Do you know? Not sure.
I don't think so.
Problems?
I don't know if you covered, but there's something that Nathan had, and like for premature babies, they have like a neurosis in their bowels.
Yes,
He had a perforated
necrotizing.
bowel. Yeah,
Yeah.
I had that.
I don't think I do.
Oh, okay. Wasn't
Yeah.
common and very premature.
Yes, yeah, necrotizing enterocolitis.
Mm-hmm.
And that's where part of the bowel necrosis, because the oxygen is going to go to the most important organs, which is the brain and the heart. So they, initially they get deprived of oxygen in their bowel, and so it causes some necrosis. Now, did they have to have surgery then?
Oh yeah, but he was on like a week old when it happened.
Wow.
Yeah. They removed
It's usually
part
from
of
that
it.
initial insult. Yeah.
But yeah, they did the surgery.
So they did a bowel resection. He didn't have a colostomy.
Yeah, and he had a colostomy, but he didn't get to come home until they reversed it.
Okay.
So he was in there another month because they wanted to reverse.
Was it an ileostomy or?
I can't remember. He's got a really bad
Probably
belly
ileostomy.
button. Like,
yeah.
Even though, like I said, he was only like a pound, and they found him.
So they just have a lot of problems.
Yeah.
He's recouped. That's all.
Oh yeah.
So, what happens is the increased volume there's an increased volume of blood to the lungs with the patent ductus arteriosus, which causes congestion in the lungs, right? It's like congestive heart failure, kind of. The blood accumulates in the lungs and causes congestion, respiratory problems, CO2 retention. These babies have real bounding. Real closely. This can be managed a lot of times with diuretics, just like we do with congestive heart failure, or indomethacin, which is a steroid, or surgically, when medical management has not corrected it.
What was the medication?
Indomethacin and diuretics. Another problem, this is why it's so important that moms get good prenatal care, right? Sometimes it can't be helped, but hopefully it can be picked up on quickly and moms get the best care. Preterm babies have a lot of issues. This is another issue. Intraventricular hemorrhage. That's a hemorrhage in the brain. Okay? Did your babies have it?
But it went away. Like
good. It resolved okay?
Yeah.
Awesome. Because their head is so fragile and premature, the vessels, so if they were vaginally delivered, okay. So that helped. Because if they're vaginally delivered, the trauma to the head, their head is not mature enough to go down the birth canal without getting some damage. So a lot of times these babies have bleeds. So it can be from injury. And this is the most severe in both short-term and long-term outcomes. So this is due to the hypoxia at birth, from birth traumas, or just hypoxia at birth. The vessels rupture in the head because of the hypoxia. Typically, this is picked up within the first week of life. And it is the most common type of brain injury in our preterms. So it's important that they get enough oxygen, and hopefully the resuscitation goes well at birth. Okay, that's our preterm baby. Newborns with fetal alcoholism. These babies often have a failure to thrive in utero. Or intrauterine growth restriction. They have abnormal structural and development of their CNS system. They have a distinct facial look. There's probably a picture in your book. And there's some other anomalies that are associated with this. But these babies typically are not good feeders. They have a poor suck. They have a lot of GI problems, vomiting, trouble with solid foods. They're at risk for mental retardation. Microcephaly, which is what? Small brain. Hyperactivity. Often we see cardiac, skeletal, ocular, and renal anomalies. Cardiac, skeletal, ocular, and renal anomalies. They typically are very jittery because they're withdrawing and have abdominal distension. Nursing care, we just need to make sure that, not just that, we need to make sure that the environment's very quiet and soothing because they can be very irritable, like all our babies that are withdrawing. And as we've hit on, there's a big problem with drug abuse in our pregnant moms also. Typically, if mom's been addicted to heroin, their babies have more respiratory distress, methadone, jaundice, cocaine, congenital anomalies, and growth restriction. Also, cocaine behavioral anomalies, abnormalities, and opiates, definitely withdrawal. So with the respiratory distress, it may be just from the withdrawal or from meconium aspiration in utero. With our methadone babies, the jaundice is usually due to prematurity. They're born premature. Cocaine, skull defects, cardiac and GU defects, genitourinary defects, skull defects, cardiac and GU defects or genitourinary. And our behavioral problems with the cocaine is ADD or ADHD. So with the withdrawal from opiates, we a lot of times have to use narcotics with the baby and wean them off of it. And they will probably have issues later in life with behavior, motor development, and infection. Manifestations of our cardiac defects in our babies. The three most common are cyanosis, heart murmur, signs of congestive heart failure. So how would you pick up on that, you think, besides tachycardia, tachypnea, and diaphoresis?
Breath sounds.
Breath sounds. You hear their lungs will continue to be juicy. Sometimes these can be caused by the torch infections. I know, don't ask me to tell you what that is because we don't have it down here. Toxoplasmosis. I have to look it up.
The others, which is
And the others.
other infection.
Yes, other infections. Rubella. Okay. Cytomegalomy.
Herpes.
Herpes. Very good. All right. What's the O?
Other infection.
Yes. Very good. See, you might see that on the. And of course, alcohol can cause cardiac defects, steroid use, environmental pesticides, seizure medications. Try not to have moms on seizure medications during pregnancy, but sometimes they have to be. common cardiac defects are listed here, seen in the first 6 months of life. Bless you. And they may be repaired during the newborn period, so you'll just need to be aware of the pre and post-operative care. I'll review my test. I don't think I tested.
With us tomorrow.
Yeah, I'll have to test in 2 weeks. So yeah. Okay. I don't think I have any. All right, respiratory distress, but I'll let you know. I did. Oh, yes. Okay. So, just a recap is it's lack of sufficient surfactant causes labored respirations and increased work. Symptoms are usually immediately after birth or within 6 hours of birth. Some of our babies have 8, 9 afterwards when they start going downhill. So the first things you might pick up, or you might pick up once this occurs, is crackles in the lungs. Our little baby that ended up in NICU was a C-section baby. And our C-section babies are more at risk for this, right? Because of all the mucus that they don't get pushed out on the way out of the birth canal, out of the birth. So sometimes it's a lot. They just take a big gulp and then they've got all this mucus to get rid of, amniotic fluid to get rid of. So apnea, poor air exchange, pallor, and retractions. And the most common treatment, again, is administration of surfactant through the ET tube. But if the baby's only mildly distressed, they probably would not do that. They just need some positive pressure. And they had a neat little machine that I hadn't seen either. We used to bag our babies when they had respiratory distress, but you really don't. You got to be careful that you don't bag them too vigorously because you can damage their lungs. And this was a little like a peak kind of thing. It was barely, so it was very controlled. I forget what it was called. Do you remember that? Remember me asking? Yeah. It just kind of, just barely gave a little push. So it was more controlled. So that's of course, it's seen in most of our premature newborns. Again, administration of the surfactant, close assessment, supportive care. Increased urinary output is often an early sign that the baby is improving because the fluid moves out of the lungs. And the kidneys are diuresing. And this will allow the alveoli to open and allow more O2 in. Recap on the meconium aspiration, tail syndrome. And that is where the meconium is in the amniotic fluid, which is in the lungs. And so baby's born whilst air in, but not out. So the alveoli often rupture due to this increased pressure. It can cause a pneumothorax or pneumonia because of that trapped bacteria. Because of the particles in the meconium due to the increased pressure of trying to move the air through. And we've got the meconium blocking that process. Big thing is they get pneumonia a lot of times. So the best thing for these babies is not to overstimulate them when they're born, and try to get them suctioned out really well before they take that first breath. Anybody see a meconium standing fluid delivery? What did they do? Did they put a suction catheter down or just bulb syringe? They kind of got a little less invasively. It was a C-section. Oh, okay. Usually what I did in labor and delivery when I worked there was the head would be delivered and, suction the baby out really good, either put a catheter down in their stomach and, bring it all the way out to try to get all of that in their airway cleared out. And so when they took that first breath, hopefully they wouldn't suck any meconium fluid in.
I've seen it a couple times, but they're really not invasive at all.
They're
The
not.
bulb syringe, they just kind of hold it kind of across their forearm, let
Yeah,
them just work it out
down
themselves.
and try to just let them work. Yeah, they're not as.
If they're going to the active distress, they'll take them to table and suction them, but usually don't get that.
Okay. So they don't put an endotracheal tube down and suction. We did that for a while in labor and delivery. They would keep, not stimulate the baby, and then get them over there and put a T tube down, endotracheal tube, and respiratory or the pediatrician or whatever would suction out below the cords to try to keep it down. But they don't seem to get so worked up about that. Okay, so a lot of times, if this occurs, the fluid being aspirated during the first few breaths, bigger suctioning, but they don't do that too much anymore. May be transported to NICU, put on a ventilator. ECMO is a type of ventilator they put these babies on, give them surfactant. They're sick babies if they aspirate. Baby in an isolette or a warmer, 1 day old, 29 weeker. This is for the parents. The parents have certain tasks that they have to meet. With a preemie baby, you don't get to have that bonding time. They whisk that baby away. So there's, there can be some issues with bonding, and so, we have to help moms and dads be able to get that task complete. So they have to, I can't read my notes. They have to perceive the infant's medical condition and needs, adapt to the infant's hospital environment. We do take, as nurses in the NICU, we take a lot of the care of the baby, but we need to also remember that we need to give them little things to do so they can feel like they are the parent. But again, we don't want too much stimulation, maybe weeks before you can actually touch your baby. Did you get to touch your baby?
Not for, I think I had to get home until like 2 weeks after they were born, and I could only hold him like in the right place.
Yeah.
Like skin to skin took a lot longer, and Michael would never, like his stats would drop even when you put up the blanket because they made it completely dark.
Yeah.
Picking up the blanket, that little spike would make him feel like his stats are crazy, so we'd have to put it right
Heart
back
rate
on.
drops down, stop breathing. Yeah. Because they're not supposed to be out there. But that's hard on parents to not be able to touch their baby. But so, sometimes it's a couple of weeks before they can actually even touch their baby inside the isolette. So we're working towards that. Typically, what they find is the baby will be discharged on their due date, close to their due date. How close were yours? So yours was like 6 weeks.
Yeah,
And that
pretty
close.
close. Yeah, because they were due August 22nd, and they were born May 6th. So Michael came home right around end of August, and Nathan came home around the end of September.
Okay. Yes, it will.
Because of the, they had to do the reversal.
Oh,
That's the only reason why.
So we have to kind of start them, getting involved so they know they can bond and know that they're going to be responsible and take responsibility when they need to. Sometimes we lose these babies, so sometimes they have to cope with the death of their infant. These babies, it's like you try to give encouragement and things are going good, but then they can have problems that occur on down the line. So they might be doing really good the first week, but then the next week they have other issues. So we're positive, but not overly positive because we say that too. We say
very matter of fact.
Yeah. That we're not out of the woods yet. This is good, but they're still very sick babies. So, and then it just mentions some of the maladaptive responses: failure to visit the infant or call. That's a problem. And just withdrawing from the infant, not interacting. And I won't read all those, but just not bonding with that baby, but you're just not having. Some people just can't deal with that because there is a risk of losing that baby, so they just choose not to bond at all with that baby. Some of them are taking the baby home. So all of those, so those are unhealthy. Adaptive or visiting, calling, involved. All those. Feeling more parental confidence, attachment with the baby, all that good stuff. And you're realistic of the infant and their potential needs at the time of discharge. Unfortunately, when I talk about abuse, preterm babies are at a high risk of abuse because they have so many needs. So we need to prepare our parents to the best that we can. And like Stephanie said, when she took the boys home, she still had a lot of work to do with them, and it can be overwhelming.
We had to take classes before we could bring them home. And then before we brought them home, we had to stay the night at the hospital with them in the room.
Good.
So, good. It used to, like I said, Michael came home first, and he had oxygen, the heart monitor constantly, and it was like you had to change their diaper a certain way. It was a lot of different.
Yeah.
I had 2 other children at the time, so it was a lot different stuff we had to do with them.
You couldn't work, right?
You didn't work, did you? No. No.
Wow.
I would have lost my. So we had weekly eye appointments, gastro appointments, pulmonary.
So that can be another stressor that, mom, maybe she was working full time and maybe the primary breadwinner and she didn't do that anymore. So it's a lot. Babies can be born with cleft lip and cleft palate. Remember, we were checking our babies with our assessment. Cleft lip, of course, you can see on the outside very obviously, but the cleft palate sometimes can be missed if you don't take your finger and go all the way back on their palate and make sure it's intact. Can have both or one or the other. There is a predisposition, genetic predisposition. So cleft lip with or without cleft palate results with when the maxillary processes fail to fuse together. Normally this happens, the union of the upper lip is complete by the 7th week. So what do you think can happen? So if you don't know you're pregnant and you've exposed yourself to something, this can be what happens. So it's so important to have, know that you're pregnant early and start taking care of yourself right away, because that's when all this development is happening. Higher risk if maternal smoking's involved, alcohol, anticonvulsants, steroids, or illegal drugs. Folate and folic acid also helps this. And it can be one of many other different syndromes in a child, but majority of babies don't have any other abnormalities or other things. Management of these babies, they have to have a special bottle and nipple. And we have to remember these moms and dads are grieving if they did not know ahead of time the loss of their perfect looking child. So we have to be aware of that and help them get through that. So our job, one of our jobs should be to point out the positives. Oh, what beautiful eyes, or beautiful hair. Point out all the positives that we can. Usually the cleft lip repair they do within the first 6 months by a plastic surgeon. And the palate varies, repair of the palate varies. So, yeah, that's a good point. Emotional support for the parents, showing pictures of how good these can be repaired. They really do look good afterwards. And there are support groups. That made them feel so much better, I'm sure. Great.
Because they had no idea.
I don't think that must not show up on the ultrasounds.
No, it was like 5 years ago. So.
Oh, yeah. And maybe they should have done the ultrasound. Yeah, they just missed it. Okay, so after the surgery, of course, they have to put the baby in soft elbow restraints so they can't get their hands up to their mouth. Of course, they have to be supine position. Maybe on some medicine for pain to minimize the crying, because we want to try to keep that lip as still as possible. And with the cleft palate repair, we tell moms not to use any metal utensils or straws because we don't want any damage to happen to the palate. They may have some abnormal tooth development. Hearing and speech problems sometimes are also part of the problem. Speech makes sense. Hearing, apparently, just some of them have some hearing problems. A GI alteration that we might see in some of our babies is called pyloric stenosis. There is a genetic predisposition. And this is just obstruction of the circular muscle of the pyloric canal. Results in stenosis. And that's the passage between the stomach and the duodenum. And it becomes inflamed, edematous, and leads to narrowing. Hypergastrinemia can be the cause, which is too much gastrin, which is the hormone that stimulates secretion of the gastric juice by the parietal cells of the stomach. So this can be noticed about 2 to 8 weeks, when the baby's like 2 to 8 weeks old. What you'll see is the infant's hungry, irritable, fails to gain weight, projectile vomiting, right, because it's not moving through. I guess the hypergastриnemia can be treated with erythromycin. So these babies can get dehydrated, of course. They have electrolyte issues, metabolic acidosis. And what you'll see is peristaltic waves on the abdomen. You can almost see them. You can actually see them sometimes, where it's trying to push that food through pylorus. So the surgery would be a pyloromyectomy. And this can be done laparoscopically. And what they do is they actually split the pyloric muscle. And that allows the passage of food and fluid. So if you have a baby that comes in not gaining weight, projectile vomiting, and we're not talking just spitting up, we're talking shooting it across the room, because there is a lot of pressure coming behind that. This would be something to think about. Here's a great little picture of that. How little that was, how big the stomach is. Trying to get that through there. There we go. Another problem we can see with our newborns is gastroesophageal reflux in our babies. So, like I said, our babies spit a lot, or can spit a lot, but this is regurgitation that continues and increases in frequency. And everybody knows this is the gastric contents going back into the esophagus. And that's due to the relaxation of the lower esophageal sphincter. This affects about 50% of infants 0 to 3 months. You may have this with their babies? Yeah. So again, a little spitting up is normal because of the weak cardiac sphincter of the stomach, but regurgitation that continues and increases could be birth. These babies have poor weight gain, again, recurrent vomiting, they're irritable. My granddaughter was diagnosed with this. She was just, they were just like, oh my gosh, we're never going to have another child. And come to find out, she had GERD. She really wasn't throwing up. So she was just really irritable, really irritable. And of course, there is a risk of aspiration with this and apnea. But they may just have their back and respiratory symptoms like wheezing and apnea. So these babies eat often but still lose weight. And this is just diagnosed with history of their feeding patterns. So they get medication and make feeding modifications. Which can consist of thickened feedings. Definitely, like there's Enfamil AR, acid reflux, and positioning them upright for 20 to 30 minutes after they eat. Smaller feedings to avoid overdistension of the stomach. If they can elevate the head of the baby's bed, burp frequently, definitely have that little syringe so they can keep the nose and mouth clear. And they actually do prescribe them Zantac and Pepsi. That inhibits the histamine receptors. thus blocking the gastric acid secretion. All right, we just have a couple more. Mothers relinquishing their infants. And ideally, we want our moms to relinquish their infants as opposed to not take care of their infants, right? But adoption is great for certain moms. And these moms tend to be single, white, never married, adolescents, that their families have encouraged them to have their baby adopted. You don't see this as much in Black or Hispanic cultures. Most people that do choose to have their babies adopted have a higher education and income level, and they have higher future educational or career goals. They want to go to college if they're an adolescent, and that their mother and father support them in adopting the baby out. Some just feel like they're not emotionally ready for the responsibility, or their partner may strongly disapprove of the pregnancy, so they would be doing it by themselves. Some are forced to adopt their babies out due to their life choices, like illicit drug use. They might just lose their baby. Although we talked to some nurses on the floor, it is very discouraging. The babies that go home with moms that have a history of drug abuse. It is very alarming. Ideally, that would be the best thing in a lot of situations. But some of them are forced to give their baby up for adoption because of that, or a past history of abusing children, or if they're incarcerated. So when a mother who is relinquishing her baby is admitted to the birthing unit, the nurse needs to respect any special request for the birth. Some moms want to hold that baby for a little bit after the birth, and some don't. So you just want to, discuss with them what they want to happen at the time of the birth, and allow them to voice their emotions, verbalize their feelings. And they find that often seeing that infant aids in the grieving process, and it provides them an opportunity to say goodbye. That's all they want. Because it's a loss. They've had this baby moving in their uterus, they've nurtured that baby, and they want to see that baby and have that goodbye. She may feel a strong attachment and love for that baby, and the nurse needs to make sure that she assures her that her feelings don't mean that she's made the wrong decision. That relinquishing their baby is often a painful act of love because they want that baby to have a better life. Something I'd like to tell you about is in 1997, the Infant Safe Haven Act was enacted to protect newborns from death caused by abandonment. And this provides mothers a means to place their baby up for adoption anonymously and ensure that the relinquished babies are left in a safe place with safe providers. So the the mother is protected from prosecution for neglect or abandonment under this law, but it has to hit certain criteria. In North Carolina, you can leave your baby up to 7 days old with a safe person. An employee on duty at a hospital healthcare center, local or district health department, fire department, for 7 days. So I think we need to be better about getting the word out on that. So we're not finding babies and crashing. But they can relinquish their baby up to 7 days. So they might think at the time, yes, I'm going to take this baby home with me, and then get home and change their mind. Well, they can take their baby, hand it to the hospital worker up to 7 days. After that, then they could be prosecuted. I think we should have longer than that, but at least we've got that to hopefully encourage our moms to give their baby to somebody safe. All right, now I'm done with all the PowerPoints. Any questions you guys have? All right, come tomorrow, we'll review, okay? And maybe do some case studies, just discuss some scenarios to try to help you with the information, okay? Any questions that you have that you can think about? All right. Keep reading and studying. Screen. Yeah, you might need to refer to that.